We're going to talk about musculoskeletal impairments today. So things that happen to your, really what this is going to be is more about skeletal issues. So things that are going to surround joints, okay, and then things that are going to happen in your back, around the vertebrae, and because of all of that, you're going to tend to get some compression and things on nerves where they leave the spinal cord and all of that, and so that causes some nerve-related pain, some muscle weakness and stuff. So a lot of this is going to be very, very simply about things that are going on in your joints, okay? So we're going to talk about a couple of kind of purely skeletal-related issues, okay? Something called osteoporosis. Then we're going to talk about osteoarthritis and rheumatoid arthritis, and then we'll finish off talking about low back pain and why low back pain is, in many ways, the scourge of sort of all of our existences in that particular way. Okay? So, again, a little bit of anatomy to start with. You guys don't have to know all of these kinds of things, but this is what a bone looks like, okay? You guys probably remember what some of this kind of stuff is, okay? And so we've got different portions of the bones, right? You're going to have the apophysis on the ends, kind of the growth plates. Then you've got the longer portion in the middle. This would be like a femur, if we're going to look at this. And then we're going to have stuff going on at either end of most of our bones where we're going to have cartilage and things where it's going to articulate and form a joint with an adjacent bone, okay? Things to remember about bones. Different areas of bones are made up of slightly different types of material. And so because of that, some of them are stronger than others, some of them have a little bit more blood flow than others, but in general, there's not a huge amount of blood flow in our bones, okay? So you're gonna have the stuff on the inside portion of your bones that's very, very spongy. It's called trabeculae bone, or trabecular bone. That's going to be here. And then more of the kind of calcified, mineral, kind of high mineral density bone is going to exist kind of along the outside, okay? So the key thing to remember about bones is that just like skeletal muscle, just like mitochondria, just like cardiac tissue, bones are always in a state of remodeling. What I mean by this is your bones, there's always this very delicate balance between the deposition of mineral, the deposition of calcium into bones, and the breaking down of calcium out of those bones to be used in other parts of the body, okay? And so there are a couple of cell types that I want you to know, and they are called osteoclasts and osteoblasts, okay? So an osteoblast is a cell that makes new bone, okay? It's not really exactly that simple and straightforward, but for our purposes in class, that's what I want you guys to know. Osteoblasts make new bone, okay? Osteoclasts do the exact opposite. They break down bone to pull out the calcium, okay? You consume calcium in food and drinks and with supplements every day, and then you place stress on the bones, and kind of the balance of all of that is going to either stimulate greater osteoblast action or greater osteoclast action. And so from all of this, in an ideal world, we'd like for them to be roughly equal, or we would like for the osteoblast activity to predominate. As osteoblast activity predominates, you put more mineral into your bones become stronger, okay? And that's a good thing because it protects us from fractures and things like that, okay? So there is a condition that is especially prevalent in women called osteoporosis. And in osteoporosis, what happens is that bone resorption or osteoclast activity very much outstrips osteoblast activity, okay? So what happens as you become osteoporotic is the osteoclast activity predominates. They start pulling calcium out of your bones to put it into circulation, to use in other tissues, okay? And that means that your bones, and it's especially prominent in bones in the spine and in the hips, okay, those bones are going to become weaker and more brittle, okay? The trabecular bone is going to atrophy, the bone becomes more and more porous, and this is going to be quantified by what we call low bone mass or low bone mineral density, okay? The bones become more like, if you guys ever, this is probably, maybe not all of you, but like, you ever had like a chicken wing or a chicken bone or something, like bird bones, you break them open, they're hollow so they can fly, they weigh less. Your bones aren't going to become hollow, but it's kind of the similar thing, that the bones become much, much less dense. They're much more brittle. They're much easier to break. So that can manifest in a couple of ways. One, you fall down, you break something. Not great, but not the end of the world. The bigger issue is that as you become osteoporotic and the bone becomes weaker, then you're going to get deterioration at individual joints, and that can begin to affect posture. That can begin to affect how you can walk, so it can affect your gait, okay? And then there very often will be, if this is how grandma has this abnormal curvature in her spine, because it is becoming weaker and it can no longer support like the weight of her head and her neck, then her posture changes. And as her posture changes, there can be more severe knock-on effects, right? Or that we're going to see where you get herniated disc, you get nerve damage, you can become arthritic because of these kinds of things. And so it can be this progressive process, okay? So here, if we look at in the kind of in the neck of the femur here, kind of right where it's going to fit into it, the acetabulum, what you're going to see is, here's what normal bone matrix looks like. Bones have little holes in them. They are slightly porous, okay, but they're not super duper porous. As you become osteoporotic, then you're going to see very much that all of these pores are going to get bigger and bigger, and so there's less actual stuff in your bones, so it's much, much easier, kind of like a honeycomb, to be able to smish them and have them break apart, okay? The single best way for us to quantify whether or not you are osteoporotic is to do a DEXA scan. This is the DEXA that we talked about when we talked about how we measure body composition. And so the DEXA is a very sophisticated X-ray, and while it can give us muscle mass and fat mass, it can also tell us in very, very fine detail how much mineral or how dense your bones are, and we can use it to look at bones in a particular area. So we can look in the hips, we can look in sort of the lumbar spine, we can look in the cervical spine, we can look in your hands, in your feet, okay? Wherever we would like to, we can draw areas of interest. Primarily, where we look for osteoporosis, where we have lots of data, is here in the hips, okay? At the sort of neck of the femur right here, okay? Right at the head of the femur. And so the way that we quantify whether or not you are osteoporotic is by calculating something called a Z-score. It's a fancy statistical term that lets us understand if there is an average of all people of a certain age, or all women of a certain age, or men of a certain age. We can calculate how far off of that average a typical person varies. And then if you are 3 times as far away from that average as a typical person, then we say you have osteoporosis. That your Z-score is 3 or greater. And so here we have a 68-year-old woman that has good or normal bone mineral density for someone her age. And so you're going to look at it, you can see how it looks a little bit darker, a little brighter in here. And her number comes out kind of right in this kind of bottom part of the green area. So she is right at a Z-score of 0, okay, for somebody that's her age. Here you have a 75-year-old woman. You will notice how it looks a little bit darker here. There's less density. The calcium and the minerals in the bone make it look very, very bright. It's a little bit darker. you get her sort of signal intensity range, and it falls down here, and she is now down into this red area, which we're going to call she's osteoporotic. Okay, so in order to diagnose this, we need a DEXA scan. In order to really understand all of this, we need a DEXA scan from all of you ladies, especially now. We need to know where you are when you're kind of in and around your peak bone mineral density, so that it's much easier for us to track any kind of changes that happen as you age. This becomes especially prevalent after menopause, ladies, okay? After menopause. You may be worried about having hot flashes or things like that that are going to go along with the decline in estrogen, but those will eventually dissipate. Osteoporosis is the thing that comes after all of that. The lack of estrogen, okay, really hampers osteoblast function. So this is much more prevalent in women, although in men we will see it. Okay? So if you are osteoporotic, there's about a 50% disability rate following hip fracture. Okay? Not nearly that high in non-osteoporotic people. In people that are osteoporotic, there's about 1 in 5 will die in the first year following their hip fracture. They don't die because of the hip fracture, but they probably become sedentary. They have cardiovascular disease and some other kind of host of stuff that's going to go into all of this. Okay? The secondary consequences of all of this, because of the degeneration in the joints, is we're going to see pain in the joints. We lose mobility, we lose independence, right? Your ability to perform activities of daily living is going to decline. And as you will note here, this sort of hypothetical woman has gotten shorter, okay? And we have this kind of curvature in the spine that is a little bit abnormal. We also begin to see impaired body image. And as you guys see next week, as we age, one of the things that becomes a really, really big issue, not that it's not a big issue now, is depression, okay? Is lowered self-esteem, lowered feelings of worth, and things like that. And some of that can be driven by body image and changes and things that may be happening with osteoporosis. So in addition to kind of less pain, better mobility, and all of this, there may be some body image issues that go into this. So if we can find a way to prevent this, that can have very, very pronounced positive effects. Okay? Places that tend to be the most at risk for the development of osteoporosis. Vertebrae, okay, are going to be a big issue. And this is one of the areas, because of the way that they function and how they hold your posture, and as you get spinal deterioration or vertebral deterioration, the chance for that to have knock-on issues with low back pain and nerve damage and stuff can become very, very at risk. Okay? In the neck of the femur, right? You fall, you break your hip, becomes a big issue there. We see lots of stuff in the wrist. When you fall and you put your hand down to brace your fall, you're going to break your wrist. Okay? Anybody broken your wrist? Like falling off of, like on a skateboard or on roller skates or rollerblades, or you just fell over because your roommate was being a dumbass or something like that and shoved you down. Okay? Then these are the big places. Things to keep in mind, okay? The wrist is tricky because we have pretty low bone mineral density in our wrist to begin with, because we don't load the wrist. There's not a whole lot in the PowerPoint slides about this, but I want to talk very briefly about how do we get your bones to grow, okay? How do we get them to grow? Well, the primary way that we get bones to strengthen themselves and deposit more mineral is not by eating calcium supplements, okay? One of the big marketing things is you're going through osteoporosis, ladies, you're post-menopause, take a calcium supplement. That's perfectly fine. It's probably a good thing, especially if you don't eat adequate amounts of calcium in your diet, okay? That's sort of the same thing, though, of eat protein, it will make your muscles bigger. Maybe, but the bigger issue, and the one thing that drives bone mineral deposition, is loading of the bones, okay? Loading of the bones. So let's try this. Zach, can you stand up for me? I know this is great Zoom kind of things, but Zach, I want you to load your femurs. I want you to put a load on your femur right now. What would you think we should do to load your femur? Okay, do squat. Okay, just stand there too. So you guys think he's loading his femur? Is there a load? Is his body weight being supported through his femur standing there? You bet it is. Okay. When you do a squat, can you mind go down and do a squat and hold it at the bottom? Okay. What is happening based upon where his center of gravity is at his femur? His femur is essentially perpendicular to his body weight at this point. You can come up, Zach. What do you guys think is happening in his femur as he squats and is down here to come back up? Are there forces being applied across his femur? Maddie, you're shaking your head yes, you think so? What direction are those forces being applied relative to the way his femur is positioned? So if my femur is like this, it's horizontal, and I'm doing a squat and I'm going up and down, right? I'm applying forces that are going to try to bend my femur. Did you guys know that? Every time you do a squat, imperceptibly, your femur flexes just a little bit. It bends just a little bit. Okay, thank you, Zach. You can sit down. Okay, every time you stand up, I'm loading my spine right now, especially my lumbar spine. Okay, because I'm carrying the weight of my sort of upper body through the spine. Gravity is pressing it together. Okay, so if I want to have good, strong bones, I have to put loads across those bones. And I put loads across those bones by lifting things, by running, by jumping, by standing, by walking. Okay? That's how we get bone mineral deposition. Anybody heard of, maybe I've talked about this before, I don't remember. Anybody heard something called the Red Queen hypothesis? It's from Alice in Wonderland. It's a sort of principle in biology. And it's the idea that you're running as fast as you can to stay in the same place. Okay? Ladies, especially for you guys post-menopause, what you're going to try to do is load your bones as much as you possibly can in an effort to hang on to whatever bone mineral density you've been able to accumulate up into that point. Realistically, ladies, y'all have got another 5 or 6 years to add bone mineral density. You really get up to kind of late 20s, maybe 30 to reach peak bone mineral density. Some of you have already peaked, okay? Any of you ladies that were maybe gymnasts or did anything like that, maybe you were sort of did the cheerleading where you tumble a bunch and you do lots of that kind of stuff when you were sort of a teenager, that's really good for bone mineral density. If you did squats, if you were sprinting, if you did stuff where you jumped and landed a bunch, that's really good for bone mineral density. Okay? That's really good for bone mineral density. So we need to load bones. Grandma needs to squat. Grandma needs to do what we call a military press, where you sit upright and you press stuff up over your head because it compresses your spine and it loads those vertebrae. Grandma needs to get the weight off the squat rack and just stand there with it because it compresses her spine. That is transferred down through her hips and things. Okay? So being active, lifting weights, doing higher intensity, high force things like running and jumping are good for bone mineral density. Okay? Ladies, if you haven't done much of this in your life up until now, now's a great time to start. Okay, now's a great time to start. There's other issues that we don't really cover in this class, but it is prevalent in both men and in women that have eating disorders. Okay, people that are anorexic, then they tend to have sort of greater prevalence of osteoporosis because you eat and then you purge. It would be if you're bulimic, you're anorexic, you basically starve yourself, or people that have been bulimic where you eat and then you purge, you don't have enough time to absorb. Those kinds of things can have some real issues with all of this as well. Okay, so there we go. Okay, so the physical activity recommendations for people that have osteoporosis, the main objective is to increase bone mass using high impact exercise. Okay, so we don't really know what the optimal exercise regime is. What I can tell you is that running and walking are better than riding a bike. There's some staggeringly bad bone mineral density in the hips of elite cyclists because they spend all of their time on a bike, right? So, so one of our faculty members, Dr. Deborah Bimbin, she studies this in bone health. They do really interesting stuff. If you look in people that do weight-supported exercise, biking, rowing, things like that, rowers have really good on like one hand, they've got really good wrist density. They tend to be pretty good, not as bad as cyclists because the way they do stuff with their legs, they get a pretty decent load through their hips, but it's all weight supported. So you're only pushing against whatever kind of force you're able to generate. You're not having to carry your body weight. So runners tend to be better. They've done stuff with soccer players, and they find really, really good or better bone mineral density in their non-dominant leg because they plant and then they kick. And the plant leg is the one that bears all of the, gets all the high load and things because they're kicking with the other one. So some kind of really fascinating stuff. But weight-bearing aerobic exercise, high impact, high velocity, resistance training tends to be really, really good choices for populations that can do it. I know that I joke a lot about grandma needs to go to CrossFit, right? But in some ways, if it can be done safely, those are the kinds of high impact, high velocity, high intensity exercises that can potentially benefit people that have osteoporosis. Okay. Okay. So we're going to shift out of that and talk about another type of bone disorder that is more common, and depending upon how we define disability is going to be either the first or the second leading cause of adult onset disability in the entire world, right? And that is something called osteoarthritis. So we're going to talk about two distinct kinds of arthritis. But we're going to start off with osteo because it's the one that is the most prevalent, okay? Osteoarthritis is essentially the degeneration of a joint that has been accompanied by inflammation, swelling, and pain, okay? So at the articulation where two bones are going to meet, that's where we're going to have this degenerative articular injury, okay? What tends to happen is the cartilage that sits between the bones and cushions and lubricates that joint, the cartilage deteriorates and will eventually go away, okay? As the cartilage goes away and wears out, then these bones are going to make contact with each other. As they contact each other, as that friction goes up, that's going to lead to damage to the bone, it's going to lead to the deposition of bone spurs and things, which then leads to an immune response, which we get swelling and pain, and then that promotes being sedentary, and that further promotes weakness and things in those joints, okay? So that's going to be a big issue. The unfortunate part about osteoarthritis is all of us that were active, or, you know, I say us, many of you guys, if you've been active throughout your life, you're actually at a greater chance of developing osteoarthritis than somebody that's never been active. They may have a host of other problems, but we've loaded our joints and already have worn out some of our cartilage to some extent in the midst of all of this. Okay, so you guys don't have to know the different kinds of joints, but I'm just putting some in here for you to see and to look at. But remember, the anatomy of an articulation is that we're going to have these synovial joints. The bones are going to come into close contact. There's going to be this cartilaginous pad that typically exists in between. There's a cavity that surrounds all of that, where there's going to be what we call synovial fluid, okay, which functions like motor oil or something. It's a lubricant. It helps keep this healthy and helps make it so that the joint, as it slides across the cartilaginous pad, can do so with as little friction as possible, okay? And so this area here, as the cartilage begins to wear out, then we're going to get inflammation. You're going to get bone-on-bone interaction. It's going to have bone spurs, which are going to look like it's kind of more grinding kind of things that are going to go on. It's going to have problems where there's going to be less synovial fluid. We're going to get inflammation. You're going to get swelling and a whole bunch of stuff that goes on here, with the end being it fucking hurts, okay? That's the end product. Your joint wears out and it hurts a lot, okay? A lot. Because it hurts, you lose range of motion. Can't move as far, okay, through some of these things. One, because the articulation won't let you, but two, because it also hurts. As you lose range of motion, you lose strength, you lose mobility, and eventually then you can't do things, okay? That's the problem. So it affects more than 20 million people in the U.S. This is a thing that I need to try to talk about, okay? Because I always ask a question about this, and then we get a little bit of confusion, okay? Osteoarthritis in and of itself is not an inflammatory condition, okay? It is not an autoimmune condition. What happens is the joints degenerate, and then you get some inflammation secondary to that, and that causes pain. As you guys will see with rheumatoid arthritis, it is an autoimmune disorder where the inflammation is the disease, okay? The inflammation attacks the joint. Otherwise, the joint is fine, okay? This one is degeneration, then some level of inflammation, whereas rheumatoid arthritis is lots of inflammation, and maybe secondary to that, there will be some joint degeneration. So I want to make that very, very clear, okay? So what we know, though, is that if people can overcome the pain associated with exercise and with osteoarthritis, that exercise can be really, really good as a treatment, okay, as a treatment for osteoarthritis. We don't fully understand why and how, but it is, okay? So here we've got a healthy knee joint. Here is going to be an osteoarthritic knee joint, okay? One of the best ways to diagnose these kinds of things is to take an x-ray, and what you can look at here, so you've got some swelling and stuff, but there's this degeneration. There's no real cartilage that's going on in there. You're going to get what they call hypertrophy or spurring of the bone down in here, and you'll note how this looks much more smooth and round and kind of a nice articulating surface, and this does not look that way, okay? Anybody ever seen a kidney stone under like a 5 or 10 times bifocal microscope? Google that shit, okay? Kidney stones look like little like diamonds that have like all these little points on them, and we wonder why they hurt so much when you try to pass them. It's because they have all of these little razor sharp edges on them. That in some ways is what sort of happens at your bones, okay, or at the ends of your bones in those joints as you begin to develop osteoarthritis, is it becomes very rough. Lots of little kind of nicky points that are going to be on there that when they press on the other end of the bone can cause further damage, okay? Not great. We narrow the articular space, you get bone on bone. That's part of what's going to cause pain, okay? So here you're going to see, okay, we've got a person here and here. You will note, looking at their knees as well, how we can see that there's kind of this swelling and stuff that's going on. Here we've got a little bit of articular space there. This one, it's basically bone on bone, okay? They're just right on top of each other. This one, in his left leg, he's got it a little bit of space on the medial side, but on the lateral side, it's very much, right, just looking right at each other. It kind of looks just like that, okay? So, osteoarthritis, much like hypertension, much like type 2 diabetes, much like osteoporosis, is a disease of aging, okay? We don't often see osteoarthritis in people until they're into their 50s or 60s or 70s, unless you've done some kind of highly repetitive, highly damaging type of activity throughout your life, okay? Cade, you and I are at a much increased risk of having it in our shoulders, throwing a baseball for forever. You see football athletes, they get it a lot in their neck, in their knees, and things from, one, lots of running and squatting and those kind of use, but also from, they just get damaged from being hit a whole bunch in those things. You see it in your fingers a lot. People that do manual labor jobs, load joints all the time, they can tend to be at a higher risk. We see it a lot in your knees and in your hips, okay? Knees and hips. So how do we treat it? Initially, we try to do non-surgical treatments, okay? You can take painkillers, you take what are called non-steroidal anti-inflammatory drugs, or NSAIDs. This is aspirin, Advil, Aleve, okay? Or their prescription strength analogs, okay? If we need, we can do intra-articular steroid injections, which help to reduce inflammation and those kinds of things, all right? When I was, and if we don't at the time, it was a stupid thing to do, but when I was 16, I had a cortisone injection in my right shoulder because I had inflammation and I have bone-on-bone interaction that's in there. It's not doing too bad today, but I can do this. Those of you on Zoom can't see this, but I'm basically pronating at my shoulder with turning my thumb on the inside. If you feel right here, you can feel the head of my humerus brush under my acromion process. You can put it right there and you can feel it. It's not great. So we can do steroid injections, okay? I've had these steroid injections in my spine as well, kind of up in my neck. It's kind of becoming a pretty standard practice to do those epidurally in that way. So you can just try to treat the symptoms. We treat the pain, allow you to keep moving. We can try to do some exercise and those kinds of things. Activity we think is good if you can manage the pain. Weight loss tends to be a big issue, okay? We see lots of knee and hip osteoarthritis in people that are obese. They've been carrying that extra weight their entire life. That puts extra stress on your joints. So lose a little bit of that weight and we can be in a better place. The most kind of invasive thing that we can do that will provide actually a lot of pain relief and a lot of increase in mobility. You want to see some wild things, YouTube knee replacement surgery, okay, is joint replacements. What you see here in the picture, this is an artificial knee, okay? We anchor this on the femur side, we anchor another thing on the tibia side, and then you create our own kind of new articulation point. They've gotten really sophisticated with both the knee and the hip joints that we can use to replace. And they move very much like a regular knee joint should or a regular hip joint should. If you have this surgery done, once you recover from the surgery and the trauma of having them take a giant hammer and literally hammer this in to the end of your femur. They will cut a little bit and then they just whack it with a hammer and hammer it in and glue it in on either end. Once you recover from that, you feel immediately better. Much, much less pain, much more mobility, much easier time getting around, okay? And that may last for 10 years or 15 years, and you got to have it done again. My father-in-law has had one hip replaced twice, and the other hip replaced once. And so, and it's been a big help for him. These are things that we can do in essence to kind of try to treat these things. Okay. All right, let's pause here. We'll take 5 minutes. Then we'll talk about rheumatoid arthritis, and we'll finish off by talking about low back pain. Okay. So let's come back, guys, let's just come back at noon. Okay, come back at noon. All right, so let's talk about rheumatoid arthritis, and then we'll do some low back pain, and we can all get out of here. Okay? So rheumatoid arthritis is going to present with many of the same symptoms and kind of functional issues that osteoarthritis does. Okay? You're going to have joint pain. You're going to have swelling in and around the joints. Okay? The issue with rheumatoid is that it tends to be multi-joint, okay? It's not just going to occur in the joints that you have loaded or used a bunch throughout your life. It tends to occur across many, many joints in the body simultaneously, okay? Rheumatoid arthritis is luckily much less common than osteoarthritis, okay? And it is an autoimmune disorder that leads to what we call an inflammatory condition. Your immune system thinks that your joint is a foreign substance, okay? And so it attacks the cartilage, it attacks the synovial fluid, and because of all of that, it calls in lots of immune cells, and we get this very large amount of swelling, large amount of pain in your joints, okay? There is no known cure for rheumatoid arthritis. You can do a joint replacement, but that doesn't fix the inflammatory condition, okay? The best cure or the best treatment for rheumatoid arthritis is a medication that essentially knocks back or attenuates the function of your immune system. Right? You guys may see commercials on TV. I think it's Enbrel or there's several other ones that what they do is they blunt immune function. The side effect is that you essentially have HIV, right? You are a person that has a compromised immune function. And so it's like, don't travel to areas where you could get tuberculosis or these other kinds of, other kinds of diseases that are more common that we can potentially normally fight off. Okay? So it's kind of the good and the bad. I take the medicine, it knocks back my RA, I have less pain, I can do things, but now I'm super susceptible to a cold or pneumonia or something like that. Okay? So there's lots of symptoms. You tend to see these nodules at the joint. They're especially prominent in the hands and the feet, where your joints, like your knuckles and things, will swell. There's lots and lots of pain and tenderness at the joint. Lots of stiffness in that joint from having all that extra fluid and stuff that's going to be around there. So in a lot of ways, what it looks like in your functional problems are very similar to what we see with osteoarthritis. Okay? Pain, weakness, stiffness in the joints, all of which can lead to disability. Okay? So again, healthy joint on the left, on the right here's a consequence of rheumatoid arthritis. And so we're going to get all of this immune system, okay, it's going to, immune response, we get all kinds of additional fluid that accumulates, and eventually what happens, because the immune system attacks the cartilage, then it can begin to erode the cartilage, and then we can begin to get bone erosion on top of all of that, and so progressively, rheumatoid arthritis can lead to osteoarthritis. So now you've got both. So it can be really, really bad. So a lot of exercises for people that have RA are going to involve just like moving and flexing the joint and trying to maintain range of motion and things in those joints, okay? So one of the recommendations for people that have arthritis of either type is that you need to exercise. One of the biggest barriers to people with arthritis to get them to exercise is they're worried that if I exercise, I'm going to make things worse, okay? it hurts for me to walk. What the hell is going to happen if I run? What's going to happen if I squat or something like that? And there's very little evidence that exercise will worsen or exacerbate arthritis. Okay? There's very good evidence that it strengthens the joints and increases range of motion, decreases pain. Okay? So our physical activity recommendations are very similar for other healthy individuals that are on a sort of a similar kind of age and risk factor plan. We just want to make sure that we are cognizant of their functional limitations, cognizant that they may be experiencing more or less pain on a certain day, and that we treat the pain, we modify exercises to accommodate their range of motion or lack thereof, and we get them to do as much as they can. Okay? All right. So the last thing that I want us to talk about with kind of bone and joint disorders is low back pain. Okay? So it depends from year to year, but you can make an argument that either osteoarthritis or low back pain or chronic low back pain are the two leading causes of adult onset disability. Okay? Any of you guys, anybody have low back pain? Okay. Lily does? Okay? Lily, how would you describe it? You have to pick out some words to describe it, maybe that aren't curse words. Uh-huh. Mm-hmm. Okay. Would you describe it as dull and aching or sharp and shooting? Okay. Yeah. Okay. So low back pain, okay, and really you can talk about this for any place kind of along the spinal column, but it tends to be most prominent in the low back because we put more pressure on the lumbar spine. But it's pain that is often accompanied by kind of muscle tightness or muscle tension and stiffness in the low back, okay, below the ribs, okay, but above the inferior gluteal fold. So typically somewhere like right here. Think lumbar spine, okay, or maybe lumbar spine in like S1, S2 kinds of regions. Staggering numbers here. 80% of people in North America will suffer low back pain at some point in your life. 4 out of every 5 people. Okay? 4 out of every 5. About 20% of Americans will experience, 1 in 5 will have chronic low back pain, which is this pain that will persist for 3 to 6 months or longer. Okay? It is the second most common by the year I pulled this. It was number 2. Osteoarthritis was number 1. Okay? It is the most common reason that people report missing work. If you look at the data, I don't know how they calculate it, but the data tells us that basically every person will miss a day of work at some point in their life due to low back pain, which doesn't jive with that only 80% of people will have low back pain. I don't know how we bridge that gap, but that's what the CDC says. Okay? So the total cost from healthcare costs and lost work productivity are somewhere between $100 and $200 billion just from low back pain. Okay? The other problem with low back pain, with nerve pain, is common over-the-counter pain medications don't work very well. Okay? Unlike arthritis, where Advil and aspirin and those things can do a reasonable job, when it's nerve pain, that's not going to get the job done. Okay? We need the heavy stuff, which of course then leads to opioid addiction. Okay? One of the most common reasons for addiction to opioids is I had low back pain. Okay? I started taking it, I got injured at work, and then I started me on Oxycontin, something like that, and then we get addicted to those kinds of things. All right? So one of the key ways to reduce the chances of disability for people with low back pain is you need to try to stay physically active, but you have to do so in kind of a safe way. Okay? So we're going to look at classifying low back pain into pain that is associated with a specific spinal cause. You have degeneration at L3, which is then causing compression in the foraminal space where the nerves live. Okay? You may have pain associated with spinal stenosis, which may mean that there is narrowing in that space or narrowing in the spinal column, and you're going to get less space so that those nerves are in contact with the bone. Okay? Or, which I again have a hard time believing this, there is this idea of non-specific pain, which is about 85% of all causes, where your back hurts, you don't have a herniated disc, you don't necessarily have spinal stenosis. In some ways, it just hurts. It is in some ways idiopathic. We don't know why it's happening, yet it's happening. Okay, so we call acute low back pain less than 6 weeks, subacute is 6 to 12, and then chronic is most of the time defined as greater than 3 months. Sometimes it's 6 months. It mostly depends. Okay, but generally 3 months is kind of the big issue. Okay, to understand some of the underlying cause of low back pain, we need to go back and appreciate what spinal anatomy and the articular anatomy of your vertebrae are going to be. Okay, if you look in the spinal column, okay, we have nerves that exit the spinal column at each individual vertebra. Okay, and so here we're looking at them in the sagittal plane. Here's going to be kind of a cross section. It's going to look like this, right? You've got the vertebral body that's going to have that cartilaginous intervertebral disc. Okay, you've got the cord in the very middle that's going to run kind of up and down through there. And then we have these spinous processes and things that are going to project off the back of our individual vertebrae. And then in between the spinous process, okay, through this little hole that is called the foramen, you're going to have nerves that are going to leave or branch off of the spinal cord and exit in these bunches out of the spinal cord. And once they exit, then they're going to run out and go connect to other organs, other tissues, okay? But the nerves that come out of here are both afferent and efferent nerves. So they're going to have things that control your ability to recruit muscles. They're also going to have nerves that control your ability to feel things and perceive things. Pain, touch, hot, cold, all of that. So when you get narrowing in these spaces, or you get inflammation in these spaces where the nerves come in and go out, you tend to get both sensory and motor side impairments. It hurts, but I'm also weak at all of that. I can't contract my muscle. Or it hurts, but it also alternatively is very tingly, and I can't feel things like when I try to touch things. It feels weird, okay? Because it affects everything as it kind of comes out of it, okay? So the place where one vertebrae articulates with its sort of the next vertebrae is called the motion segment, which, you know, is a deal that you guys don't necessarily have to know, but that's what that's going to be called, where it's going to make kind of this close contact and where around it can kind of move around on that cartilaginous pattern. Okay, so things to appreciate about spinal anatomy. The cartilaginous intervertebral disc is really, really important. Okay, and it is going to function in many ways as a shock absorber. And so it is in here in the middle. And so as you stand, as you carry things, as you walk, you're going to get those vertebrae either being pushed up or pushed down, or sometimes both, onto each other, and they're going to squish this intervertebral disc. So we need this disc to be both soft, but also firm, kind of like a nice mattress or something, okay? And so it's going to have two distinct kind of sets of tissue in this disc. Something in the middle that is called the nucleus pulposus, and then surrounding that is something called the annulus fibrosus. And so the outer layer is more fibrous, it's more stretchy and kind of tough, and then the pulposus in the middle is going to have fluid and things in it. Water and fluid are really good shock absorbers. They can move, it can swish, it can dissipate force really, really well. Okay? One problem with all of this, though, is if you load your spine a bunch from running, jumping, repetitive stress at work, and maybe you do so with bad form, is we can get something called a vertebral disc herniation. Okay? When you get a herniated disc, the annulus fibrosus ruptures. Okay? It tears, it ruptures, and that allows basically the nucleus pulposus, which is real squishy, to squish out of its normal place in the middle and push out into the foraminal space and compress those nerve bundles as they leave the spinal cord. Okay? It narrows this particular space. So L5-S1 is the joint that is the most vulnerable to injury for two reasons. One, it bears the greatest load because it's down at the bottom, but also because of that normal curvature that we see at the back end of the lumbar spine and the start of the sacral spine. With that curve, then it's very easy to get the center of weight from above, your shoulders and your head, off center of what's happening at S1, and that's going to create kind of a shearing, and it makes it very, very unstable, okay? And so at that curve, you can do things, you can squish the disc in a weird way, you can tear it, and you can get this herniation, okay? So this is kind of a top-down view. Here's a side view, and you will note that we've pushed part of the disc out, and it's now compressing the nerves as they leave. When this happens, it hurts, and it hurts a lot. But you're also going to have trouble contracting the muscle where this is going to happen. Okay? We can map very easily, based upon symptomology, which disc is most likely affected. Okay? If you are having weakness and pain, like down in your quads or your hamstrings, okay, you're losing feeling in those places, or you're having stuff in your feet, we can trace that back exactly to the vertebral space where the nerves that are going to go to those muscles or those body segments are located. Okay? So I have narrowing because of bone spurs. You can also get bone spurs and bone growth out of here into the foraminal space. I have narrowing in the foraminal space at C4, C5 in my neck from smashing my head into people playing football, I'm sure, when I was younger. When I irritated it once because I slept funny, more things for you guys to look forward to as you age. I slept funny. I had shooting pain sort of down my trap muscle, my trapezius, through my anterior delt, down my bicep, down sort of on the radius side here, and into my thumb. It's a perfect C5 dermatome sort of thing. My other fingers are fine. I still have numbness kind of tingly numbness in the tip of my thumb here, okay? But everything else was fine. Tricep, fine. My other fingers, fine. Thumb, messed up, okay? Bicep, messed up. Tricep, fine. It's very strange, very disconcerting, but it tracks then from all of that. We can figure out exactly where in the spinal cord this is happening, okay? So this is going to happen. You're going to get these things pushed out. You guys can see here's some MRIs. I tried to get my dad to let me have his MRI of his low back. We went to see a specialist in Oklahoma City, not this past weekend, but 2 weekends ago. And we're going to talk about scoliosis in a second. But he has scoliosis and several disc herniations due to that and some disc degeneration. His back is really gnarly. It looks really, really bad, but it's the same kind of thing, right? He's got a lot of pain, he's got a lot of numbness and weakness. And so we can diagnose all of that without even looking at the MRIs a huge amount, okay? But as you can see here, right, we're getting a little bit right here. This is, I think, L5, S1 right there. This is more kind of at S1, S2 down there. Okay, and then you can see it kind of push out with all of those kinds of things. So that's kind of what it looks like. What do we do for people that have low back pain? We have found that exercise is a reasonable treatment. Okay, so we try to do some aerobic exercise with pain education and these kinds of things. But what tends to happen is if there are no other comorbidities, physical activity for folks with low back pain is basically whatever it would be for other age kind of matched people. It's just symptom of pain or symptom of movement limited because of this. Okay, walking is good so the symptoms don't worsen. Low back pain and these things, spinal anatomy is one of the places where stretching is actually beneficial. Okay, so if you can stretch and do things, you can potentially alter posture and increase range of motion a little bit, and that can relieve some of the stress and the pain that is put up, the compression that is put on there. Anybody ever seen they're like these like deals you get in and it stretches you out and then it flips you over and it inverts you, like a traction kind of thing? What that does is it is meant to allow gravity to try to pull apart, right, and lengthen out some of those segments in your spine, and it can provide some level of relief. This is a deal that is really, really down to the nerves get compressed, and if we can eliminate some of the structural issues that compress the nerves, you will feel better. Once they get compressed, then you get inflammation. We can clear up the inflammation, but that may take months to do all of that, okay? So there's some things that we're going to see with all of this. The last bit and some stuff that tends to be related to back pain, especially low back pain, is abnormal curvatures of the spine, okay? Normal spine curvature, this is called kyphosis, where you have an abnormal kind of curve in the upper back. Lordosis is kind of abnormal posterior tilt, right, in the low back, so that there's this more dip forward in the lumbar and then more of a dip out in the sacral spine. But you can imagine if you're trying to hold weight over the top of all of this, right, that you're going to put some of these things, there's going to be a lot of pressure on the outside and the inside of some of these because of this extra curve. And then this is the one that's the most common, is it's called scoliosis. And that's an abnormal lateral curvature of the spine, left or right, okay? If you looked at my dad's, his goes and it curves out like this on the right, and then it twists and it comes way back over this way to go left, and then it comes back up. He has like an S in his back. And as you can imagine, as it really bends here through his lumbar spine, at each one of those, it's like stacking blocks together where you've got one that's here, the other one is kind of offset, so it wants to tilt the other direction. So then the one above it kind of tilts back the other way to try to compensate for balance, and it creates all of these alignment problems, and you can end up in a really, really bad place, okay? Scoliosis can be progressive. They still check, ladies, if they check y'all for scoliosis when you're in like elementary school or junior high or something. They never really check men for scoliosis, but it is still relatively common. And if you've already got some, and you're like my father, and you're a crazy runner, they think that as he ran a bunch, it actually sort of pound, that it sort of bent it more over time. And then something hurts, so you change your posture, and then it changes the curvature and all of those kinds of things, okay? So very common. So we can treat some of these things. You can treat scoliosis by attaching, they're going to have to attach rods basically that run from S1 to T12 in his spine and sort of bend everything back together, straighten it out, open them all up. He was joking the other day that in our pictures when my wife and I got married, my dad was several inches taller than me. I am now as tall, if not taller than him. As you age, this gets worse. As you get degeneration and a little bit of loss of bone mineral density, then it gets a little bit worse, and you shrink. My wife's aunt had this done, and she magically got 3 inches taller from before to after surgery because they straightened her out and those things. Other ways that we can treat some of this. So here, these are the people they put this rod in. So this kind of looks like what my dad's spine looks like. His curves are more like this. But other things that you can do is they will go in, and again, I should have asked Dr. Larson for her picture, or Dr. Mike, because they just had spinal fusion. But what happens, you've got these things, they come in and they straighten out and they pin together these two vertebrae. It's called a fusion. They screw them together so that when they articulate, they move at the same time, and it keeps that abnormal kind of compression on one side or the other from happening. The problem is when you do a fusion surgery, or if you get what my dad's going to have done, is that all of these things move together. And so when they move together, you lose overall range of motion. That's one of the really cool things about the spine, having all of those individual vertebrae, is in theory, you can move ever so slightly at each one of those joints. And so it allows for lots of different sort of ranges of motion and things as we go around. So when you get the fusion done, it will relieve the pressure and fix this, but you lose range of motion. And then eventually over time, that can also become a problem. Okay, so take home message, generally, physical activity is beneficial for folks with skeletal disorders, regardless of the kind. We need to tailor the exercise program to the individual. If you've got osteoporosis, one of our big goals is going to be to try to do higher weight, higher intensity stuff to try to maintain or increase bone mineral density. If you've got osteoarthritis, or you've got low back pain or rheumatoid, you've got a pain condition, what we want to do then is to try and tailor our exercises to limit pain and counteract some of the limitations that we have on your individual range of motion. So basically, we would use the same principles, right? Like 60 to 80% of maximal strength, or 40 or 50% of heart rate reserve to 80% of heart rate reserve. We just need to kind of focus on how we can manipulate these things around with the person's individual symptomatology. Okay. Anybody have questions? Seeing none and hearing none. And